Welcome all to the today's masterclass of SBAs and EMQs. So we'll be discussing today about the SBAs and EMQs of guideline number 69, GTG number 69, that is management of nausea, vomiting in pregnancy and hyperemesis gravidarum. We begin with our tagline, that is master the MRCG with concept-oriented clarity. So we have many SBAs and EMQs. Dr. Amrita, can you start first question?
Yes, sir. Question: a 28-year-old woman at 9 weeks gestation is admitted with hyperemesis gravidarum requiring IV hydration and antiemetics. She is dehydrated with normal sodium and low potassium levels on admission bloods. You decide to start IV fluids and antiemetics. Which of the following is the most appropriate initial management for IV hydration and antiemetic therapy in this patient? Option A, 5% dextrose infusion with metoclopramide IV bolus. Option B, 0.9% NS with potassium chloride guided by daily electrolytes and metoclopramide slow IV bolus. Option C, Ringer's lactate with ondansetron as a first line antiemetic. Option D, 5% dextrose with additional magnesium sulfate and chlorpromazine IM. Option E, 0.45% saline with glucose and promethazine as the first line antiemetic. So the answer is option B. 0.9% NS with potassium chloride guided by daily electrolytes and metoclopramide slow IV bolus over 3 minutes.
Yes. So just don't remember a 0.9% normal saline. Remember the complete sentence because you will have this same option. The first option may be 0.9% normal saline. There may be another option 0.9% normal saline with KCl. Okay. There will be another option 0.9% saline with KCl guided by daily electrolytes. And in this question, they have asked about the antiemetics. If the question they would not have asked about antiemetics, your answer would not have included metoclopramide. Okay. You got it. Then why metoclopramide? Why not other ondansetron or something like that? Now here the patient is got a severe hyperemesis gravidarum, so she requires IV. Then uh, we do not know whether she has been tried with the first line or, but in other options, the IV fluid of choice is this is the only correct option. Along with this can be okay, but ringer lactate is not a choice. Okay, so sometimes your antiemetic is correct but the fluid is not appropriate, so that is what you need to look into it. So the answer is 0.9% normal saline with potassium chloride guided by the daily electrolytes and metoclopramide given slowly IV bolus. This particular word is also very important because it causes extrapyramidal reaction. Okay, so IV fluids, the recommended IV hydration in hyperemesis gravidarum is 0.9% normal saline with addition of potassium chloride in each bag with daily monitoring of electrolytes guided by the electrolytes. Okay. 5% dextrose alone is avoided initially due to the risk of Wernicke's encephalopathy and hyponatremia. Antiemetics, metoclopramide is safe and effective as a second line antiemetic and may be used alone or in combination. It should be administered a slow bolus injection over at least 3 minutes to reduce the risk of extrapyramidal side effects. Okay, so this is what is the concept over here. Okay, now why the other options are wrong? Option A is wrong because 5% dextrose is not recommended. Okay, option C is incorrect because ringer lactate is not appropriate choice. Ondansetron is usually considered as a second line antiemetic after cyclizine and prochlorperazine is used. Then option D is incorrect because 5% dextrose again not a first drug of choice. Okay, and option E is incorrect because again 0.45% normal saline with glucose is hypotonic and not appropriate for initial resuscitation. Okay, promethazine can be used first line, but it is not included in this scenario, focusing on metoclopramide. Okay, so that is what is the concept over here. Now, next question, Dr. Sinchana, you want to start?
Yes, sir. A 27-year-old woman at 9 weeks gestation presents with severe nausea and vomiting. She is unable to tolerate oral intake, reports reduced urine output, and feels dizzy on standing. Examination shows tachycardia and dry mucous membranes. Which of the following features best describes hyperemesis gravidarum from nausea and vomiting of pregnancy? A. Onset before 16 weeks of gestation. B. Presence of nausea and vomiting. C. Inability to eat and drink normally with interference in daily activities. D. Nausea associated with vomiting. E. Associated with fetal gender. Answer is C. Inability to eat and drink normally with interference in daily activities.
Yes, absolutely correct. Because actually, other options also you will feel that they are not wrong, but the most appropriate answer is inability to eat and drink normally with interference in daily activities. Okay, so let's see. Option answer is C. Inability to eat and drink normally with interference in daily activities. And the expression is nausea vomiting in pregnancy is defined as a nausea vomiting uh, with onset before 16 weeks without other causes. Okay, so option A, B, and D will include the definition of nausea vomiting in pregnancy. Hyperemesis is a severe form where nausea and vomiting can cause inability to eat and drink normally, strongly limits daily activities, and may show dehydration. Okay, that is the option C. Association with the fetal gender is not diagnostic. This reflects the current definition, shifting away from only weight loss, electrolyte imbalance toward the functional limitation dehydration. If you see the older guideline was including the weight loss. There has to be 5% weight loss and there should be electrolyte imbalance to say that it is a hyperemesis gravidarum. But this current guideline, which is updated in 2024, it does not rely on these objective investigations. Okay, so it is mainly on the quality of life. So and the quality of life RCOG gives lot of focus, so you should consider these particular things. Yes, go ahead with Dr. Sinchana. Next question. Yes, Dr.
A
Sinchana, can you
26
hear?
Yes, sir.
Yeah.
A 26-year-old woman at 9 weeks gestation attends the antenatal clinic and asks how common nausea and vomiting are during pregnancy. Which of the best following best represents the approximate percentage of pregnant women who experience nausea and or vomiting during pregnancy? Option A 10%, option B 25%, option C 50%, option D 70%, option E 90%. Answer is option E 90%.
Absolutely correct. Here, only thing is that previous guideline was mentioning 80%. This guideline mentions 90%. So you
Right.
just see to it that if 90% is there, you select the 90%. Okay. By any chance, if 90% is not there and 80% is there, then you will select 80%. And they are asking about the nausea and vomiting in pregnancy. There are two different prevalences. NVP has got a different prevalence and hyperemesis has got a different prevalence. Both of which these are numericals. Make a separate notebook for these numericals. Okay, so explanation is nausea and vomiting of pregnancy affects approximately 90% of pregnant women. It is the commonest indication for hospitalization in early pregnancy, with hospital stays typically 3 to 4 days when severe. Remember, in general, hospital stay is 3 to 4 days. Okay, hyperemesis gravidarum is the severe form of nausea vomiting in pregnancy, affecting 0.3 to 3.6% of pregnancies, causing significant impact on quality of life and oral intake. So here what we have to learn is incidence is 0.3 to 3.6 for hyperemesis gravidarum. Hospital stay is 3 to 4 days. Okay, and there's a affection of the quality of life. Okay, so these are the things which you should remember here. Next question, Dr. Amrita, you want to go ahead with
Yes, sir.
this?
Yes, sir. A question: a 25-year-old woman at 9 weeks gestation is admitted with hyperemesis gravidarum. She had persistent vomiting, dehydration, and ketonuria. Blood tests are performed as a part of an initial assessment. Which of the following lab findings is most likely to be seen in this patient with hyperemesis gravidarum? A. Hyponatremia with low serum urea and raised hematocrit. Option B. Hypernatremia with raised serum urea and low hematocrit. Option C, hyperkalemia with hypochloremic metabolic acidosis. D, low T4 with raised TSH requiring treatment with levothyroxine. E, liver transaminase are raised in over 70% of women with hyperemesis. Sir, option A, hyponatremia with low serum urea and raised hematocrit.
Yes, absolutely correct. Here it is, they will confuse you with the same thing. Like in one of the things they'll give low sodium, in other thing they'll give low potassium, and they will give permutations and combination of this. And most of the time we get confused with this urea. Okay, so urea is also low in mild to moderate forms. Okay, or even severe also. But in extreme cases, when there is acute kidney injury, then creatinine, this urea might be higher. But in the beginning, the typical electrolyte imbalance will include low sodium, low potassium, low serum urea, and hematocrit will be raised. Okay, so this is a recall question. This has been asked. Okay, so one of the frequently asked questions. So answer is hyponatremia with low serum urea and raised hematocrit. So electrolyte and lab findings in hyperemesis gravidarum: hyponatremia, hypokalemia, low serum urea, and hematocrit due to hemoconcentration. Ketonuria are typical, and metabolic hypochloremic alkalosis is common. Okay, it's a metabolic alkalosis, hypochloremic. Okay, because HCl is going out. Okay, is common during vomiting unless it is a severe. At that time, it will be metabolic acidosis. Again, this can be a question. What is the metabolic change? It is a metabolic hypochloremic alkalosis. This can be an SBA. Okay. Then there are further SBAs subsequently also. What happens to the thyroid function test? Up to 67% of women with hyperemesis gravidarum will have abnormal thyroid function test with a raised T4 and low TSH, which do not require treatment if the cause is clear and the patient is improving. What happens to the LFTs? LFTs are abnormal in 40% of women with hyperemesis gravidarum, commonly showing raised transaminase. Okay, so these are the. So why the other options are wrong? Opposite of the typical findings, that is, option B they have given wrong. Hypokalemia is seen, not the hyperkalemia. Okay. Then raised T4 and low TSH can occur, but it does not require treatment in a straightforward hyperemesis gravidarum. LFT abnormalities are seen in 40% of cases and not in 70% of cases. So you may confuse in these percentages also. Okay. Next question. Who wants to take Sinchana?
Yes, sir. A 28-year-old woman is admitted with hyperemesis gravidarum at 10 weeks gestation. Blood tests show elevated transaminases. Approximately what percentage of women with hyperemesis gravidarum are found to have abnormal liver function test? A 10%, B 25%, C 40%, D 60%, E 80%. Answer is C 40%.
So L comes alphabet first, then T. So we have only two figures to remember. One is a 40, another is a 67. So lower figure is for LFTs, that is 40. Okay. Just a moment. No. Just a moment. We have not this. So answer is C. 40%. Liver function tests are abnormal up to 40% of women. Okay. We'll go for the next question. Yes. Go ahead.
A 30-year-old woman admitted for hyperemesis gravidarum has thyroid function test showing raised T4 and low TSH levels. She is otherwise stable and improving with supportive management. Abnormal thyroid function tests are found in approximately what proportion of women with the hyperemesis gravidarum? Option A 10%, option B 33%, option C 50%, option D 67%, option E 90%. Answer is option D 67%, that is two-thirds of the cases.
Correct. So we have already seen the explanation also. So we will not go into detail. Only thing is that you remember this is due to the cross reactivity of SCG with the TSH receptor and does not require treatment in straightforward cases where the cause is clear and the patient is improving. Sometimes they use the word gestational thyrotoxicosis. Okay. So as a diagnosis, so that also sometimes can be asked as a SB. Next, go ahead, Sinchana.
A 26-year-old woman at 9 weeks of gestation is admitted with hyperemesis gravidarum. She is dehydrated and ketotic but is now improving with intravenous fluids and antiemetics. Her thyroid function test shows TSH less than zero point 0.1 milliunits per liter, free T4 mildly elevated. She is otherwise stable and improving with treatment. What is the most appropriate next step in her management regarding thyroid function abnormality? A. Start carbimazole to control hyperthyroidism. B. Start propionate to control hyperthyroidism. C. Repeat thyroid function test after delivery. D. No specific treatment is required after for the thyroid abnormality. E. Is referred to endocrinology for urgent review. Answer is option D. No specific treatment is required for thyroid
Yes,
abnormality.
this also we have seen the explanation. Okay, 67% you get thyroid function abnormalities. This is transient gestational thyrotoxicosis. Okay, from high SCG levels because of the cross reactivity. If the patient is clinically euthyroid and improving with supportive treatment, no specific antithyroid treatment is needed. TFT abnormalities are typically resolved as the hyperemesis gravidarum improves and routine antithyroid medications are not indicated. Okay, endocrine referral is not required unless the patient has a persistent symptom, signs of hyperthyroidism or severe biochemical thyrotoxicosis. Okay, so that is what is the explanation. Next, Dr. Amrita now.
Yes, sir. Question: a 30-year-old woman at 10 weeks gestation is admitted with hyperemesis gravidarum, unresponsive to first-line antiemetics. You plan to start ondansetron. Which of the following statements regarding ondansetron use in the first trimester is most accurate? Option A: ondansetron is contraindicated in the first trimester due to high risk of fetal cardiac defects. Option B: ondansetron increases the absolute risk of orofacial clefting from 100 per from 11 per 10,000 to 14 per 10,000 births. Option C: ondansetron significantly increases the risk of neural tube defects and should be avoided. Option D: ondansetron should only be used after 20 weeks gestation. Option E: ondansetron is associated with a tenfold increase in the risk of orofacial clefting. Sir, option B.
Yes, doctor. If you read guideline carefully, then you will, you feel that the options are mostly correct. First thing, whether you know the appropriate malformation which is associated with this or not.
Orofacial clefting.
Yes, yes. So you know, then you come to the respective options. Okay, then you get confused. How much tenfold or how much? Remember, it is a negligible increase in the orofacial clefting, which is there from 11 to 14 per 10,000. So it increases just by 3 per 10,000. Okay, so counseling is must in this patient. So this is the what is the correct answer. Okay. So everything you have to remember. Ondansetron increases the absolute risk of orofacial clefting from 11 to 14 per 10,000 births. Ondansetron is considered for safe for hyperemesis gravidarum if the first line antiemetics are ineffective. There is a very small increase in absolute risk of orofacial clefting from 11 to 14 per 10,000 when used in the first trimester. This small increase should be balanced against the risk of poorly managed hyperemesis gravidarum. Ondansetron is not associated with a high or significant increase in fetal cardiac defects or neural tube defects and should not be delayed to after 20 weeks if clinically indicated. So that is why other options are wrong. Continue, Dr. Amrita.
Yes. Question: a 28-year-old woman at 9 weeks gestation with hyperemesis gravidarum is started on metoclopramide as a second line antiemetic. What adverse effect should you counsel her before starting treatment? A: Steven Johnson syndrome. B: extrapyramidal side effects. C: ototoxicity. D: renal impairment. E: persistent hyperglycemia. So the answer is option B: extrapyramidal side effects.
Yeah, absolutely correct. Absolutely correct. So option is B, extrapyramidal side effects. So metoclopramide can cause extrapyramidal side effects. So it is used as a second line therapy and should be given by slow IV bolus or at least 3 minutes to minimize the risk. So when you have an option, look for everything. When look for complete option. Okay. Slow IV, only IV metoclopramide option. And if you have slow IV, and what happens, what is there when you solve EMQs. In EMQs, option will be alphabetical. Like the one which begins with A will be first. The one which begins with B. So you will look for metoclopramide is the. So you will look into somewhere in the middle or lower, and it will be you will find metoclopramide IV. But they may give start as a slow IV metoclopramide to be given over a period of 3 minutes as a bolus. So you unless you read the complete options, you feel that you have answered it correctly, but you have missed the complete correct answer. Okay, that is why reading all options is also very important. Go ahead.
Question. A 29-year-old woman at 10 weeks gestation is admitted with hyperemesis gravidarum and is now developing epigastric burning and retrosternal discomfort suggestive of GERD due to recurrent vomiting. Which of the following is the most appropriate pharmacological treatment for gastroesophageal reflux disease of this patient? A. Domperidone. A. Calcium carbonate acids only. C. Histamine type 2 receptor blockers or proton pump inhibitors. D. Sucralfate alone. E. Metoclopramide. Sir, option C.
Yes. So H2 receptor blockers or PPI. Okay. So they have discussed this in the complication. Okay. Various complications in hyperemesis gravidarum. They have discussed all this. Okay. So answer is C. Histamine type 2 receptor blockers or proton pump inhibitors. Recurrent intractable vomiting in nausea, vomiting in pregnancy, or hyperemesis gravidarum can lead to GORD or esophagitis or gastritis. So H2 receptor blockers like ranitidine or proton pump inhibitors like omeprazole may be used safely in pregnancy for GORD developing in this context. Antacids alone may not be sufficient if symptoms persist, and metoclopramide, domperidone are primarily antiemetics and not first line for GORD treatment. Okay, so remember what we are dealing with. They have given you the diagnosis also. Okay, so just don't think first line, second line, third line. Okay, if we are dealing with complication like GORD, then we should know the drug of choice for GORD. Okay, that is why this question I included. Okay, next, Dr. Sinchana.
At 20, yes, sir. A 26-year-old woman at 9 weeks gestation is admitted with severe hyperemesis gravidarum and is planned for intravenous fluid resuscitation. What is the most important step to prevent Wernicke encephalopathy in this patient? Administer her a high-dose vitamin B12 prior to dextrose infusion. Administer thiamine supplementation before giving dextrose. Start dextrose infusion immediately to correct hypoglycemia. Restrict oral intake for 48 hours. Start total parenteral nutrition immediately. This B thiamine supplementation before giving dextrose.
Correct. Sometimes candidate get confused between the different vitamins. So it is the B one. Okay.
Thiamine.
So administer thiamine supplementation before giving dextrose. Okay. Nausea, vomiting, or hyperemesis gravidarum can lead to Wernicke's encephalopathy. This also you are supposed to know little bit about this. Due to thiamine or vitamin B1 deficiency, particularly if dextrose is administered before thiamine repletion. Then thiamine supplementation orally 100 milligram TDS or IV should be given to all women admitted with vomiting or severely reduced dietary intake before dextrose or parenteral nutrition. Failure to do so can precipitate Wernicke's encephalopathy, which can be life-threatening and cause irreversible neurological damage. Okay. So for each clinical scenario, select the most likely. That is the next, I guess. So continue. Yeah, continue.
A 27-year-old woman is admitted at 9 weeks of gestation with hyperemesis gravidarum requiring IV fluids and antiemetics. She is concerned about likelihood of requiring further hospital admissions later in pregnancy. Which of the following best describes the approximate proportion of women with hyperemesis gravidarum who will be readmitted within the same pregnancy? A 5%, B 10%, C 20%, D 33%, E 50%. So is it D 33%?
Yes, it is 33%. It is okay. So one third patients will get admitted in the same pregnancy again. Okay.
Yes.
So see how minor you need to read the guideline. Okay.
Yes, sir.
So option D, 33%. Almost one third, 33% of women with hyperemesis gravidarum will be readmitted with this in the same pregnancy. This reflects the recurrent and fluctuating nature of hyperemesis gravidarum despite initial inpatient management. Counseling patients regarding the potential for readmission helps to manage expectations and encourages seeking timely help for dehydration and worsening symptoms. Actually, these are just things you should know because it comes in a part 3 where a lot of communication skills are expected. Okay, so when you read, you have to concentrate on the SBA and EMQ sort of material. Okay, but you should know what is the clinical application of like a communication, what advice and all. Okay, Go ahead, Dr. Sinchi.
A 29-year-old woman at 10 weeks of gestation is admitted with severe hyperemesis gravidarum, unresponsive to initial medical management. She feels unable to continue with pregnancy due to severity of her symptoms and requests termination of pregnancy. Which of the following statement regarding termination in women with hyperemesis is most accurate? A. Termination of pregnancy should be offered immediately in all cases of refractory hyperemesis gravidarum. Approximately 10% of women with hyperemesis gravidarum undergo termination due to severity of the symptoms. See, psychiatric assessment is not indicated prior to termination in these circumstances. D. Termination is the first line management option for severe hyperemesis gravidarum. E. Corticosteroids are contraindicated in severe hyperemesis gravidarum and should not be offered prior to termination. It is B. Approximately 10% of women with hyperemesis undergo termination due to severity of symptoms.
Yes, your answer is correct. So this question, they want to test whether when is the decision for termination and how many percentage of patient will require it. But if you see, the psychiatric assessment is also included, then corticosteroids. So you have to try n number of things. So when you read superficially, you may feel that okay, there was something related to psychiatric assessment. There was something, whether it was indicated or not indicated. You get confused of all this. Okay, so your knowledge has to be very thorough. So approximately 10% of women with hyperemesis undergo termination due to severity of symptoms. Otherwise, this patient would not have opted for termination of pregnancy. Before considering termination of pregnancy, optimize treatment with antiemetics, corticosteroids, enteral tube feeding, parenteral feeding, electrolyte, metabolic correction, etc. Now, we have seen different types of enteral tube feeding. We have also seen PICC line. They also mentioned PICC line is better than the enteral tube feeding. They also mentioned that what are the complications, infection, and I guess electrolyte imbalance. So when you read even these, simultaneously your brain should start thinking, can there be additional information for SBA or EMQ? Okay. So optimize treatment and all these things. Consider a psychiatric opinion if there are mental health concerns. Decision for termination of pregnancy should be multidisciplinary. Okay, with the documentation of therapeutic failure if it is refractory. Your condition is refractory. Okay, counseling should be offered before and after the decision. Termination is not the first line of management for hyperemesis gravidarum, and corticosteroids may be used in refractory cases as a part of management. Again, corticosteroids, which corticosteroids, what is the route, how will you start, convert it to oral, then you will reduce the dose, then you will come to a lowest possible dose for maintenance. Okay, and once it is stabilized, then you over a period of time you taper it. Once the patient is on corticosteroid, you will monitor. What will you monitor? Sugar. Okay.
Sugar.
Yes, sir.
Okay. So all this, you should know. Dr. Tony, you want to say anything? Anthony, you want to say anything?
Yes.
You want to read?
Sugar and blood pressure.
Yeah. Yes. You want to read or this question, or should we go ahead?
Yes, sir. I'll read it, sir. A
Yeah.
28-year-old woman who has severe hyperemesis gravidarum requiring hospital admission in her previous pregnancy is now planning another pregnancy. She is concerned about the risk of recurrence of hyperemesis gravidarum and potential psychological impact in the postpartum period. Which of the following statements regarding hyperemesis gravidarum recurrence and psychological outcome is most accurate? A. The risk of recurrence of hyperemesis gravidarum in a future pregnancy is less than 10%. B. Women with previous hyperemesis gravidarum have a lower risk of postpartum depression. C. The recurrence risk of hyperemesis gravidarum in future pregnancies ranges between 15 to 81%. D. There is no strategy to reduce recurrence risk in future pregnancies. E. Hyperemesis gravidarum is not associated with postpartum anxiety or post-traumatic stress disorder. The answer is C. The recurrence risk of hyperemesis gravidarum in future pregnancies ranges between 15 to 81%.
Yes, it is correct. And actually, they have quoted some Netherlands study. Okay. I don't remember the details, but there is a study which they have. Actually, multiple trials will be there, and each trial may give different this particular thing, but this 51 to 81 they have taken as a final figure. So the recurrence risk is 15 to 81%. Women who experience hyperemesis gravidarum in pregnancy, recurrence risk is 15 to 81%. Hyperemesis gravidarum are associated with increased risk of postpartum depression, anxiety, and post-traumatic stress disorder. Preemptive use of antiemetics before symptoms begin in the subsequent pregnancies may reduce the recurrence risk. So what exactly you have to do in next pregnancy? Before she develops symptoms, you should start antiemetics so that the severity will be lower. Okay. Therefore, women should be counseled regarding the recurrence risk and psychological risk and preventive strategies. Okay.
A
Yes.
29-year-old woman.
Go ahead. Go ahead.
A 29-year-old woman has severe hyperemesis gravidarum, requiring hospital admissions during her pregnancy and has now delivered a healthy baby. She attends her 6-week postnatal check and reports ongoing low mood and anxiety. Which of the following postpartum complication is she at risk? Is she at increased risk of due to her history of HG? A. Postpartum hemorrhage. B. Postpartum depression, anxiety, and post-traumatic stress disorder. C. Postpartum thyroiditis. D. Puerperal sepsis. E. Postpartum cardiomyopathy. The answer is B.
Yes,
Postpartum
we have
depression,
just
anxiety,
absolutely, we have just
PTSD.
the explanation. Okay, so this reflects the psychological impact of prolonged severe illness during the pregnancy. These women should be screened and supported for mental health concerns during the postnatal period. There is no direct increased association with the PPH, thyroiditis, sepsis, or cardiomyopathy specifically related to hyperemesis gravidarum. See, there is a guideline on the mental health during the pregnancy. That guideline have also been asked multiple times. Little uncommon for routine our practice, but that guideline is very, very important. At what time you are going to screen, what are the different ways to screen the patient and all, we will discuss when we'll discuss that guideline. Now we have EMQ. Now I think Dr. Sinchana, you start this EMQ.
Yes, sir.
Thank you,
For
Dr.
each scenario,
Yeah.
For each scenario, select the most likely side effect associated with antiemetic used. Each option may be used once or more than once or not at all. Options are A. Extrapyramidal side effects, B. Constipation, C. Sedation and drowsiness, D. QT prolongation, E. Headache, F. Diarrhea, ototoxicity, Steven Johnson syndrome, tachycardia, hypertension, hyperglycemia, oropharyngeal candidiasis.
Read the
Scenario
question,
1.
Arvind. Yeah.
A 28-year-old woman with hyperemesis gravidarum is started on metoclopramide and develops involuntary facial movements and neck stiffness. Side effect is extrapyramidal side effect.
So option A. Okay.
A.
See, this is a very simple question. Actually, this particular guideline mainly SBS will be asked because we want to cover EMQs. So I have just included possible EMQs. Okay, but mainly SBS will be asked, and you should practice having scenarios with long stay. Okay, so in exams, your full at least 10 to 12 lines will be there as a question. Go ahead with the next.
A 30-year-old woman is being treated with ondansetron for severe nausea vomiting pregnancy and reports shows reduced bowel movements and heart stools.
So
So
which
it
drug
indicates
here
side
is
effect constipation.
constipation. So answer
Const-
is B. Okay. So these are the simple ones actually. So extrapyramidal side effects. Metoclopramide can cause dystonia, oculogyric crisis, and other
Drowsiness.
extrapyramidal symptoms, especially in young women, and constipation due to
On
ondansetron. Okay, especially with reduced intake in hyperemesis gravidarum. Okay. Uh, Dr. Amrita, next, same options are there. So just go ahead with the third question.
Yes, sir.
Dr.
Question 3. A 27-year-old woman with hyperemesis gravidarum is treated with cyclizine and complains of feeling excessively sleepy during the day.
Yeah,
drowsiness.
just
Drowsiness.
Option.
Sir,
with
C.
correct.
Sedation and
Sedation and
drowsiness.
drowsiness.
Very simple.
Cyclism,
Next,
antihistamine.
go ahead.
Question 4. A 29-year-old woman on ondansetron for hyperemesis is found to have constipation, and you wish to monitor for another potential cardiac side effect of this drug.
QT
Sir,
prolongation.
QT prolongation. So, sir,
Yes,
in
yes.
this we will answer extrapyramidal side effects, constipation, and QT prolongation. Three.
No,
There
see,
was
it's only one option you have to select, and they have specifically asked in this question about the cardiac side
cardiac.
effects. So
Okay.
the answer will be QT prolongation. Okay.
Yes, sir.
Sometimes you may have this constipation, QT prolongation, and constipation and QT prolongation. They may ask you the side effects of ondansetron. You got it, and then you will just select constipation, which is more common. You got it. So
Yes, sir.
what is the everything about ondansetron that you should know? Now go to the last.
Question 5. Question 5. A 25-year-old woman with nausea, vomiting of pregnancy on prochlorperazine develops drowsiness and slow reaction times while working. So, sedation and drowsiness.
Yes, again sedation and drowsiness. Okay. So these antihistaminics, these drugs, first line drugs, are known to cause drowsiness and sedation, and QT prolongation is common with the ondansetron.
Ondansetron.
So actually this you can take the photograph, because if you are making the sticky notes or something like that, or you want to make a study wall, you should have these particular like metoclopramide side effects, okay, ondansetron, constipation, QT prolongation. If everything is in one place, no, it will help you in final preparation. Then you don't have time to go through whole guideline, no. So, okay, hyperemesis plus ondansetron, constipation is common. Okay, offer laxatives proactively if constipated while continuing the ondansetron. Ondansetron is not stopped unless constipation becomes severe and unmanageable. Okay, so these are the things which you should remember in managing hyperemesis gravidarum. See, when you read the guideline, do you notice that are we reading in such a minute way? Any
So, it
difference
gets
between?
better when we solve questions.
Yes, yes. Okay, they want you to implement these guidelines. Okay, so this is another for regarding the next SB EMQs which we are going to solve. So about Wernicke's encephalopathy, few things we have already discussed. Okay, so this can also, you can take a photograph. Dr. Anthony, you want to take next SBS? We are about to finish now. Next two you take, Anthony.
Yes, sir.
Yeah, yeah.
Yes, sir.
So
For each
these,
of the following clinical scenarios, select the most appropriate statement from the list of options. Each option may be used once, more than once, or not at all. Options: A. Defined as nausea and or vomiting prior to 16 weeks of gestation without other causes. B. Severe form affecting 0.3 to 3.6% of pregnant women. C. Occurs in approximately 90% of pregnant women. D. Associated with hypersensitivity to GDF-15. E. Commonest indication for hospital admission in early pregnancy. F. Usually requires hospital stay of 3 to 4 days. G. Associated with significant weight loss and electrolyte imbalance. H. Requires termination of pregnancy in most cases. I. Most cases resolved by 20-week gestation. J. Caused primarily by H. pylori infection. K. Managed effectively with corticosteroid as first-line treatment. L. More common in multiple pregnancies.
okay, the question 1 and 2 you can take one by one. Okay,
Okay.
I'll show you the
A
answers
24
again. Yeah.
a 24-year-old woman presents at 10 weeks gestation with nausea and occasional vomiting, but is able to tolerate oral intake. Examination and investigation are normal.
Yeah. You want to read it once more, or?
I want to scan through the options.
Yeah, yeah. Confirm the option.
It's
Yes. What is the? You can read the question again if you feel that you are getting confused between few options.
Okay, a 24-year-old woman presents at 10 weeks gestation with nausea and occasional vomiting, but is able to tolerate oral intake. Examination and investigation are normal.
Yeah.
That's might C. I'll go with option C, sir.
C occurs in approximately what they have asked. Following, select the most appropriate statement from the list of options. So it occurs approximately 90% of pregnant women and defined as a nausea and vomiting prior to 16 weeks of gestation without other causes. Okay. Now A and C are really confusing. We'll discuss that after the question number 2. We'll discuss.
Okay, sir. A 29-year-old woman at 8 weeks gestation presents with severe vomiting, dizziness, and dehydration, requiring hospital admission. She is unable to tolerate any oral intake.
I'll show you the answers.
B.
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 Hyperemesis gravidarum. Yes, I agree with her. B.
Okay, let's see the option.
B.
The first is option A. That is the definition of nausea and vomiting in the pregnancy. Nausea, vomiting prior to 16 weeks without other causes. And B is a severe form affecting 0.3 to 3.6 with inability to eat and drink is hyperemesis gravidarum. Okay, so here if you see the this question, 10 weeks of gestation with nausea, vomiting, what they have given you more of the parts of the definition, because 10 weeks of gestation is given, nausea, vomiting is there, but she is tolerating. So what they have given is no doubt. Then after that, it becomes a approximately 90% of women. So the first will come the diagnosis. Then how common it will be? 90%. Okay. But really, such questions are confusing. Okay. Dr. Sinchana, you go ahead with the same options are there, which we have discussed. But now
Yes, sir.
I'll show you the options again. Read the question number 3, 4, 5.
The patient is admitted with hyperemesis gravidarum and is planned for intravenous hydration and antiemetic therapy. She asked about the average length of stay in the hospital. The option is HG, commonest indication for hospital admission in no. It is F, sir. Usually requires hospital
F.
stay for 3 to
Yeah.
4 days.
Actually, this is a straight because that
Yes.
is the only option which correlates over here. But when you have such option, they will give you options like 1 to 2 days, 2 to 3 days, 3 to 4 days, and then you get confused because you have just overall remember it is less than 5. That is, if you have remembered like that, then you will get confused. So you need to know very specific. Go ahead with the
Yes.
next question.
The underlying pathophysiology of nausea vomiting in pregnancy involves this factor which causes appetite loss, taste aversion, and vomiting.
Very clear.
Correct option is associated with hypersensitivity to
D.
GDF15.
Option D. Okay, straightforward question. Next.
This condition is the most common reason for hospital admission in early pregnancy. Option is HG, commonest indication for hospital admission in early pregnancy.
Yeah. So let's see the options. F, hospital stay is 3 to 4 days. Then D, hypersensitive to GDF15. And E, nausea and vomiting is the most common indication. So you got oriented now to the SBAs and EMQs on this particular topic?
Yes, sir.
Yeah.
Yes,
Okay.
sir.
So we thank you very much. We finish our session today here. Thank you.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.